Well, it's Medical Terminology 1 again, and what we want to do in this particular video is we want to talk about some cardiovascular conditions and procedures that you might hear about in the future. Hopefully by this time you've already gone through the first video on the cardiovascular system where we talked about vocabulary and word roots and stuff like that, because if you haven't, it's going to be more difficult to understand what we're going to be talking about here. So my recommendation is if you haven't done that yet, or if you're not comfortable with that section yet, you should probably go back and review that before you go on from here. So let's go ahead, and if you have and you're ready to go, let's jump into this. First of all, the first thing we want to talk about is a word called arrhythmias, okay? And what arrhythmia means is A means without, and rhythm means without rhythm. And whenever we look at the heartbeat, what happens is if I'm looking at the heart, okay, and you look at it with an electrocardiogram with a pulse, the beats should be between 60 and 100 beats per minute, okay? That's the normal range of the heart rate, okay? If it's too low, that's what we call a bradycardia. If it's too high, that's what we call a tachycardia. The other thing that we look at when we talk about arrhythmias is when you actually feel your pulse, it should be boom, 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 like that. Sometimes with arrhythmias, it's not like that. There might be boom, 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 or boom, 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 all over the place, all kinds of different rhythms. So those are called arrhythmias. And there's a couple different types of arrhythmias. And I'll show you a couple of these when we, as we go on here. This, first of all, let me get rid of my scratches up there so you can actually see. This one up here is probably the first one that we talked about. And if we look at this, this is what's called a bradycardia. Now, you're saying, how do I know that's a bradycardia? Okay, and this is pretty simple, okay? If we look at this, this is an electrocardiogram strip. It's a strip. Sometimes we'll show you some 12-lead ECGs, which actually are nice because they're able to take a view. And what the electrocardiogram is, it's an electrical image of what's going on in the heart, the electrical current that's passing through the heart, both the direction, the magnitude, and the rate and things like that, and the timing of different things, okay? Has a number of different parts to it. What I've actually done is I put together what's called a Spark video, which is also going to be posted on media site, which will talk to you a little bit about how that electrocardiogram is obtained, okay? It's going to be helpful for you. So you can actually go back before, you can stop here and go back and look at that, or after this you could look at it and tell a little bit more about it, okay? What happens if I look here, you can see there's a box that goes from there to there. There's like a large box there. Each one of those large boxes is 0.2 seconds. Now, if we blew that up, inside that there are 5 small boxes in both the horizontal and the vertical direction inside that large box. And each of those horizontal small boxes is 0.04 seconds, 0.04 seconds. So if I have 5 of 0.04, that's where I get my 0.2 seconds. If I look at this, so if I'm looking at this, and again, my rate's between 60 and 100, let's go there. So there's 0.2 seconds, 0.4 seconds, 0.6 seconds, 0.8 seconds, there's 1 second. 1.2 seconds, 1.4 seconds, 1.6 seconds, 1.8, 2 seconds. Okay, well, already if I have 2 seconds, my rate, if my heart rate is 60 per minute, I should be having 1 beat, and this is 1 beat, this is the other, I should be having 1 every second apart. This one's 2 seconds apart. So the rate on this is about 30, okay, which would be abnormal. That's low. Because it's low, that makes it bradycardia, because I know brady means slow. Okay, so I'm able to look at this ECG really quick and see that there's a long distance. So that's 1 heartbeat right there. That's the next heartbeat right there. There's more than 2 seconds between the two. If I take 2 divided into 60, that's 30. So therefore, my rate's going to be about 30 beats per minute. Okay, so it's pretty simple to look at. We can also count the number of boxes, and they'll tell us, and we sort of go, 300 to 150 to 100 to 80 to 70, and go on down from there. But that's a little bit more complicated than we need to talk about right now. The second one right here, okay, the second ECG that we see, and let me get rid of these scratches up in here, okay, is just the opposite, okay? So I have a beat here, 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 a beat here. Now if I take this, okay, there's 0.2, 0.4, 0.6, 0.8, there's 1 second, so 5 boxes, 1, 2, 3, 4, there's 5 boxes right there. And so we have 1, 2, 3, 4 that are occurring in each 5 boxes each second. So if we multiply, that 4 by our rate's much higher here. It's well over that 100. Okay. If I look at here, this is probably about 180 beats per minute. So anyway, so what happens is going too fast. If it's going too fast, what is that? That's a tachycardia. The heart's beating too fast. And all the waves get pushed together, okay, which is something we don't have time to talk about, but it's something that we otherwise do when we do an ECG class, okay? I'd be more than happy to talk to people about that down the road if people want to learn more about electrocardiogram. Now, this one right here is called an atrial flutter, okay, an atrial flutter. And this wave right here is called the P wave, P wave, P wave. The P wave represents the electrical current that goes through the top part of the atria of the heart. What's happening in this is instead of having a atria ventricle, atria ventricle, atria ventricle, atria ventricle, in this case we're having atria, atria, atria ventricle, atria, atria, atria ventricle, atria, atria, atria ventricle. And this is called a flutter because what happens, I'm getting 3 atrial contractions for every ventricular contraction, okay? And these larger beats right here, these larger things right here, that's the electrical signal that we get when the ventricle contracts. So this is abnormal, and this is called an atrial flutter, okay? So that's an atrial flutter. It does occur every so often. You know, you might see it sometime. Now this one right here is really interesting. Now you'll see this on commercials. They say, I'm living with AFib, okay? AFib stands for atrial fibrillation, okay? And that's what we see down here. This is atrial fibrillation. Now, what does fibrillation mean? Flutter means, you know, it's regular, but fibrillation, what happens is the atria, instead of beating like it normally does, it starts to wiggle, okay? It just sort of wiggles like this. It just wiggles around. That's called fibrillation. It's just sort of wiggling. And the reason why it is normally there's one spot in the atria that starts the heartbeat. If you look at this Spark video that I'll put on Udemy site, there's one spot in the atria, and we talked about this in our previous discussion, which is called the sinus node, the sinoatrial node, or the SA node. That's where everything starts. What we have in an atrial fibrillation is all these little spots inside the atria say, I can do a better job than the SA node, and they start to send out their own signal. As a result, instead of the SA node sending the signal down to that AV node like we talked in the previous video, I have a bunch of signals in here coming from a bunch of different cells inside here, sending it to the AV node, and the AV node, it says, you know, which one do I let go through? I don't know which one's the right one. This one's here. Oh, well, they're coming fast and furious. I don't know. And what we see is all these little fluttery areas, and I shouldn't have used the word flutter, all these little wiggly areas that we see down in there. That's all those different areas in the atria that are trying to send a signal to that AV node. And that's why we see that. Now, the thing that's interesting about atrial fibrillation is let's look at the rate, or let's look at the rhythm. Big difference. Oh, it's smaller. It's even smaller yet. It's a little bit bigger. It's about the same. It's a little bit smaller, a little bit bigger, way big. What happens is they get what's a heartbeat, which is called irregular, which means it's not occurring in any kind of normal rhythm. The rhythm is totally out, and that's called an atrial fibrillation, okay? We also sometimes see something called a ventricular fibrillation, and that's what we see down in here. These are the ventricles, okay? That's a ventricle, that's a ventricle, that's a ventricle, that's a ventricle in the atrial fibrillation, but all these little wiggles here are not the atria, but it's the ventricles. So instead, the atria doing this and wiggling, and some of them getting through, and when they do get through, it causes a normal ventricular contraction. In this case, the atria are saying, gosh, I don't know what to do, and the ventricles wiggling. As a result, no blood gets pumped out of the heart. That's when you see on the crazy TV shows, he's in VFib. Get the paddles out. That's when they stick the electrical, you know, paddles on the chest and they defibrillate them. They zap them, boom, and they can see their legs fly up and their arms fly up. Say, okay, now 300 joules. They hear the machine wind up. They stick the thing in. Okay, everybody back, everybody clear. They press the little buttons and the arms and legs go flying. Okay, and what they're doing is they're trying to provide an electrical current to the heart to actually stop this. They actually try to say, I'm going to supply a stronger electrical current to the heart than the heart actually makes to try to actually temporarily stop so the heart may start again normally. Okay, so that's that. Myself, okay, I've actually had ventricular fibrillation. Okay, I don't know if that's something to be proud of. Probably not. But when I was 36, and you're going to see this a little bit later, when I was 36, I had a heart attack. I had a myocardial infarction. And I did well for a while, and then after that I started getting really lightheaded, weak, and they thought it was one of the vessels were starting to close off. So they took me in, they opened it up, they ballooned it out, did what's called a stent. They opened it up. We'll talk a little bit about stent a little bit later. They opened it up a little bit, and I was fine. I was running within about 3 days after I did the stent. And then about almost a little bit less than a year after that, I started to get shortness of breath again when I was running. And they realized that what happens is when you have a heart attack, like I mentioned in my previous video, the muscle doesn't come back, it dies, okay? Therefore, therefore it has to be replaced by other tissue, replaced by scar. And when the electrical current comes down, it gets to that area of the scar, it has to go around it. And sometimes it keeps on like a dog chasing its tail. It goes around and around and around and around and around that scar. And that sometimes causes the ventricles to start to contract really rapidly and finally goes into the ventricular fibrillation. Now, when they found out this on me, what they did is I have a little box in my chest. Okay, it's hard. Let me see if I can pop up the picture. I have a little box that's implanted in my chest. You can actually feel it right here. You actually feel the wire. So right here, and that goes into my heart. So what happens is when I run into something like this, and it's only happened 3 times, when I run into this ventricular fibrillation, what happens is this little box, as a little computer in my chest, senses that and gives me a shock. My arms and legs go flying and stuff like that. The 2 times it happened, I was asleep, so I really didn't know much. In fact, the first time I said, "Is that the phone that rang?" You know, I woke up and it was her. I had a big golden retriever, and he was sleeping by my feet, and he actually jumped up out of bed. He was whining in the corner, so maybe he felt a little bit of that shock. The last time it happened, though, I was actually in the morning and I was changing some printer ink in my printer, okay, and all of a sudden everything started to turn pretty dark, and boom, it shot me back. And my wife was up in my office when that happened. She said I just like flew back into the chair. I said, I think my defibrillator went off, went to the hospital, and then CCU for a few days, but that's that. But that's defibrillation. And fibrillation just means things are wiggling, okay? So let's look at an electrocardiogram. Let's talk about what we call congenital heart disease, okay? Congenital means with birth, okay? With genesis, with the beginning of something. And there are a couple things that do happen in this that I'll just mention that you might hear. The first one's called coarctation of the aorta. Now, we know from our diagrams before, okay, here's my aorta. My aorta is coming up in here. Well, if you look right here, see how it's narrowed? It pinches off right there. That's called a coarctation of the aorta, okay? These vessels up in here, there are 3 vessels. This one up here, okay, let me just do it in a different color. This one up here actually does 2 things. It goes to the right arm and it goes to the right side of the neck. So this would be my common carotid, and this one is called my subclavian artery. This one right here is my left common carotid, and this one over here is my left subclavian, okay? What happens is then what happens down here when it gets narrowed off, the blood pressure, because it's backing up, gets higher in the upper extremity, and then down below that in the lower extremity, the blood pressure is lower. Simply because what happens is that area of the blood supply is being cut off by where the aorta is narrowed, and that's called a coarctation of the aorta. Okay, so it's not that common, but it may occur, and sometimes it actually occurs up in here. And if it occurs in here, there might be normal pressure in this, but what happens in this side over here, if the coarctation is occurring right here, the blood flow to the left arm might be decreased. So the blood pressure in the left arm might be significantly lower than the blood pressure in the right arm. Okay. The second type of congenital defect we have here is called a patent ductus arteriosus. Okay. Now this is sort of a cool thing. Okay. This little thing right there, it looks like a little H. See a little thing comes right down there? In the fetus, okay, in the uterus, the lungs aren't working. We know that the right side of the heart sends blood to the lung, and the left side of the heart sends blood to the rest of the body. Once the blood goes to the lung from the right side of the heart, it goes back, it gets oxygen, picks up oxygen, gets rid of carbon dioxide, and comes back to the left side of the heart. However, in a fetus, how much breathing is that fetus doing inside the uterus? Close your eyes. What do you see? Nothing. It's not breathing. So why send a whole lot of blood to the lungs? So what happens is in a fetus, and this happened to all of you, when the blood leaves the right ventricle down here, it goes to the pulmonary vein, right, or pulmonary artery right here, and it's going to go towards the lungs. Some of it will continue to go to the lungs, but some of it goes right through this little opening, which is a little artery that goes into the aorta, and that blood now goes in the aorta and goes to the system, so it bypasses the lungs. Pretty cool. Just after birth, what happens is once the fetus is born, it becomes a neonate or newborn. This area closes off and stays as like a little cord that connects the bottom of the aorta with the top of the pulmonary artery down in here. And you can actually see that when you do an anatomical structure. You can actually see, you know, you dissect a cadaver or anything like that, you'll actually see that. Okay, that little thing, and it's called the ligamentum arteriosum because it's now not open. Sometimes, however, it stays open, and that's where we get the word patent. The word patent means it's open, and this should not happen after birth, but sometimes it does, and that's called a patent ductus arteriosus. Usually what they'll do is they'll watch it. It should continue to close within a couple days after birth, but if it doesn't, they have to go and surgically go in and close that off. Okay, and that's called a patent ductus arteriosus. When that duct, that tube, that little artery that connects the pulmonary artery to the aorta doesn't close just after birth like it should. Okay. The other thing that we get down here, the next type of a congenital deformity is called a septal defect. Okay. Now the septum we know means what? Wall. Sometimes what happens as the heart is developing, we have a persistent hole between the right side and the left side of the heart, which shouldn't happen. Obviously, if things in the right ventricle, they should go out the pulmonary arteries. Then the left ventricle, they should go out the aorta. If they're in the left atrium, they should go, or the right atrium, they should go to the right ventricle. If they're in the right and the left atrium, they should go in the left ventricle. Left ventricle. That's the way it goes. However, sometimes we have holes in the walls of the heart, and those are called septal defects. They create a very large murmur, and unless they close, they will have to be surgically closed at some point relatively soon. Now, we talked about the ductus arteriosus, but there's also something else. And I didn't mention this before, but between the right atrium and the left atrium, the septum, in the fetus, there's also a hole right there. So there's a hole going from the right atrium to the left atrium, and that hole is called the foramen. And we know foramen means what? Hole. Ovale. O-V-A-L-E. O-V-A-L-E. It's foramen ovale. And what that does is it does the same thing that the ductus arteriosus does. When the blood comes into the right side of the heart, instead of some of it going to the right ventricle, some of it will go from the right atrium into the left atrium, and then it goes from the left atrium to the left ventricle and out through the aorta. And that closes also just after birth. Sometimes it doesn't. Sometimes they have to go put a little graft or a patch to close that up. Okay, and that's what happens. But a septal defects could be an open or in a foramen ovale that stays open. Once it closes, actually, if you look inside the right atrium, there's a little ditch in there, good word, fossa. Fossa we know is like a little small shallow depression, and it's called the fossa ovalis after it closes naturally after birth. Okay, but sometimes it doesn't, and that would be almost like this sort of it would be a septal defect to allow abnormal flow between the right and side. Either in that case, it would be between the right and left atrium. It would go from the right atrium, which is higher pressure, to the left, it would go from the left atrium, which is higher pressure, to the right atrium. Same thing if there's blood in the left ventricle and there's a hole in the wall between the left ventricle and the right ventricle, the blood's going to go from the left ventricle into the right ventricle, which is going to actually overload the lungs and cause some problems in regards to the blood flow there. Okay, so anyway, those are septal defects. The last thing I could talk about here in congenital, and here's a ventricular septal defect. Okay, see here's the left ventricle right here. Here's the right ventricle right here. See, there's a hole right there. So blood, higher pressure on the left side going into the right side. Okay, and that's abnormal. Okay, I'm going to get rid of my picture here because I got to get to the last thing we talked about. And this is something that's not really common. Okay, and this thing that's not really common is called the tetralogy of Fallot. Tetra means four, and Fallot is the person who described this. And basically, there's four things that occur in this congenital heart defect. First of all, the first thing we have is this is the pulmonary valve right here. The pulmonary valve is narrow, so I get a pulmonary valve stenosis of that valve. There's a ventricular septal defect, and we see that septal defect right there. So blood can actually go, and go back, between the left and right ventricle. The third thing we have is the aorta. The aorta is malpositioned. Instead of being positioned over the area of the aortic valve, it's positioned closer to the area where that septal defect is. Okay, and the fourth thing is the right ventricle gets hypertrophic. Excuse me, gets hypertrophy, which means it gets larger. Okay, and that's because there's an increased blood flow that's in the right ventricle, an increased amount of blood which stretches it out, and that's called tetralogy of Fallot. Not that common, but it's something we should mention. Okay. Congestive heart failure. Okay, now people have heard about congestive heart failure, but they don't know what it is, or heart failure. Heart failure, guess what heart failure means? This is going to be deep. Ready? The heart fails. That's what it means. It means that the muscles of the walls of the ventricle can't pump out what comes into them. So in other words, when the blood comes in, if I have normal walls, okay, and this is actually abnormal over here. This is called diastolic or hypertrophic heart failure. This right here is called systolic heart failure, which is the most common. Let's say what happens is the muscle on the left side of the heart doesn't, a left ventricle doesn't work. Okay, it's getting weak, it's getting poor, it doesn't contract nearly as hard. Well, where's the blood coming from that eventually ends up in the left ventricle? It comes from those pulmonary veins that come into the left atrium. Where did they come from? They came from the lungs. Okay, so the lungs through the pulmonary veins are bringing blood into the left atrium and they're going to the left ventricle. Well, if the left ventricle isn't strong enough to pump out through the aorta what it should, what's going to happen? The blood backs up from the left ventricle into the left atrium. The blood backs up from the left atrium into the pulmonary veins, and the blood backs up from the pulmonary veins into the lungs. What happens is these, and we'll learn about this in the next time, when we talk about the respiratory system, we have small little air sacs, and around the air sacs are all these little capillaries. What happens is it increases the pressure in the capillaries start to leak, and they leak fluid, and they fill the air sacs, and they get what's called pulmonary edema. And that's what this x-ray shows. See how cloudy it looks over in here? All that cloudiness? That's because all these little air sacs are filling with fluid. Okay? And as a result, these people have all kinds of problems. They have to try to get rid of the fluid. They give them diuretics. They give them something to try to make the heart work better and all kinds of stuff. But heart failure just means the heart is not pumping out what comes back. If I have right-sided heart failure, okay, where's the blood coming that's coming to the right side of the heart? From the body. The inferior vena cava and superior vena cava come into the right atrium. It goes to the right atrium to the right ventricle. If the right ventricle can't pump it out to go to the lungs, the blood backs up in the circulation. These people get swelling in their ankles. They get large distended veins in their neck. If you look at their jugular vein in their neck, they're like bulging way out. Why? Because it's backing blood up into the superior vena cava and inferior vena cava because it can't be pumped out of the right ventricle. So the whole thing about heart failure that I think you need to remember is that what really happens in heart failure, the muscle of the ventricles is not strong enough to be able to pump out the blood that comes from it. You could have right-side heart failure, and then the swelling in the legs, the liver gets swollen, we get the jugular veins in the neck get swollen, get all distended, get all filled up. Or you can have left side heart failure when the blood backs up and the pressure backs up in the lungs. It causes fluid to leak out the capillaries, fills those little air sacs, and that's called pulmonary edema, which is actually pretty significant. Okay. Or you could have congestive or both side heart failure where all the muscle doesn't work. And next thing you know, the whole heart fails. But that's what we see with heart failure. Okay. There's a lot more. We could spend probably another 3 hours if you want on heart failure, but that's what we're talking about. Heart failure just means the muscle of the ventricle, either left or right or both, isn't strong enough or isn't powerful enough to be able to pump things out. What they do is they have something, we'll talk about it later on when we talk about abbreviations, there's something called an EF. EF stands for ejection fraction. What happens when the blood gets in the ventricle, I'm going to give you a little hint. Not all the blood that's in the ventricle gets pumped out. There's always, even at the end of that systolic, when the ventricle contracts, there's still going to be blood in the ventricle. About 60 to maybe 70% of the blood in the ventricle gets pumped out. However, what happens with heart failure, this ejection fraction starts to go down and go down and go down. And finally, when we get to like the 20s and stuff like that, it just means that there's not enough blood coming out of the heart to do much good. Okay, and that's called the ejection fraction. I'll talk about that a little bit later. Coronary artery disease. Now, we've talked about this before. And what happens is in coronary artery disease, for some reason, the inside of the artery and the coronary artery. So here's the right coronary artery going here. Here's the left coronary artery. Then it divides it to go down to the front of the heart and goes around the back of the heart with that circumflex artery right there. What happens is if there's coronary artery disease or CAD, coronary artery disease, what happens? The inside lumen to allow blood to go through, okay, the blood to go through becomes narrowed. Eventually what happens is there's going to be cracking of the wall that draws platelets. Platelets get there, they form a plug. The plug releases chemicals. The chemicals start to cause blood cells to clot in there, and then they get what's called a myocardial infarction or a heart attack, as we would say in lay terms, okay? And what happens is this occurs gradually, but usually the sudden effect of a heart attack occurs dramatically. Sometimes people have what's called angina. And angina is where basically in this situation, the lumen of the artery is narrowed, okay? the lumen of the artery is narrowed, but what happens, there's still blood getting through. However, when you walk or run or exercise or get excited, there's not enough blood to be able to go to supply the muscles of the heart. As a result, you start to get this what's called angina pectoris, or this sort of like a ischemic pain. Ischemia means a low blood supply. Now, if we look up here, these are angiograms. These are coronary angiograms. Here's a catheter. Okay, you can see the catheter, and they pass the catheter up from your leg. Okay, and through the artery of the leg up into the aorta below. When it gets into your abdomen, passes up the aorta, through the aortic arch, and they put it right where the coronary artery is, right where the aorta starts. Then they put dye in there. And what we actually see here is there's an area right here where there's really a blockage of a vessel. You can't see it. It's getting blood in here, but it's coming from these little small vessels around the outside, which are called collaterals, which are garbage. They don't do much. And we see the same thing right here. We see a blockage there. We see a narrowing right there. And that's when they sometimes go in and do like angioplasties or coronary bypass. Now, if we look down over here, we're talking about a coronary bypass, okay? And in a bypass, they could do it a couple different ways. This way, they've taken actually a vessel, usually a vein. It's not an artery. It's okay, but it's not the best. But they take a vein from the leg, and then they put a hole in the aorta, sew that vein here, and attach it down here. If this is the area where the blockage would be right here, they take that vein and attach it into the artery down here. And what happens is when the blood comes out, it's going to go down that vein. It's going to supply down in this area. So now that area is not without blood supply. Okay. A better way they actually do it now is that on the inside of the chest, there's two arteries that are just on the inside of the chest that come straight on down, and they're called the internal thoracic arteries. They can actually loosen them up, separate them from the chest wall, and swing those over. And that actually works better. They last longer than some of these veins that are put in there. Okay. But that's just called a coronary artery bypass graft. So it has a coronary artery bypass graft either by a piece of a vein that's put in there or by swinging over these internal thoracic arteries, which are inside the chest. So that's a little about coronary arteries. Okay. A couple other pathological things. Endocarditis. And endocarditis, we see this with bacterial infections. And the one common offender here is strep. Okay, there are other types of things that will cause us, but if we don't treat the strep for the entire time that we have the antibiotic, we don't kill it all. And as a result, what happens is this is an autopsy picture, so it didn't work out well for this. See all these little clumps up there? There's clumps up there. There's clumps up there. Look like little pieces of cauliflower sitting on there, and those are called vegetations. And those vegetations are basically started by the bacteria. They embed themselves. And this is the part of the valve, and that valve is lined with the endocardium, okay? And then the inside wall of the heart is the endocardium. The bacteria embed themselves in the walls, and they surround themselves with a lot of fibrous tissue to sort of protect themselves. And then as a result, it causes an abnormal blood flow, which actually, in this case, destroys the valve. Okay, and so endocarditis is basically usually an inflammation or an infection that occurs frequently after strep. That's why you take it for the full dose that you get it for a strep throat, and that prevents that. There are other bacteria that will do that as well, but that's called endocarditis. Okay, rheumatic heart disease. Okay, what happens is well, let me go down to hypertension. Okay, let's go back. Let's go talk about rheumatic heart disease. Rheumatic heart disease is frequently also caused by the strep, which is actually why it's below the endocarditis, because it's very close to the same thing. What we find is sometimes when people they have what's called rheumatic fever. Rheumatic fever. And rheumatic fever is where that strep stays in the body, and it can involve the heart, the endocarditis, but it may also involve other places like the joints. The joints get swollen, red, hot, and stuff like that. This is a pretty bad situation because most people have to be hospitalized, IV antibiotics and stuff like that. So endocarditis and rheumatic heart disease are frequently associated with the fact that there's an infection that infests not just the heart, but also other areas of the body. Hypertension. Hypertension is just another word for high blood pressure. High blood pressure, or hypertensive heart disease, okay? Now, we talked about this a little bit before. The arterioles, we know, have muscular walls. And for some reason, in some people, these muscular walls are a little bit active. They're too active, and they constrict down. They narrow down. If I'm trying to get a certain amount of blood through that small hole, and the hole is smaller, the pressure inside that vessel is greater, and the pressure starts to back up, just like we saw in heart failure. Okay? So as a result, when they take your blood pressure is much higher than where it otherwise should be. Now, here's the problem, okay, is it causes problems with the heart. Why? Because if the heart is pumping out the same amount of blood, or trying to pump out the same amount of blood through smaller vessels, the heart has to work harder. Eventually the heart says, you know what, I'm not paid to do this. This is a little bit more than I should be asked to do. And the heart starts to fail because of that. That's called hypertensive heart disease. So when we have a situation where the hypertension is causing a problem, okay, it causes the heart to have to work harder. It may result in something like a myocardial infarction, which we know is a heart disease. Hypertensive cardiomyopathy, cardio, heart, myo, musclepathy, where what happens is the heart muscle gets thicker. We get what's called a ventricular hypertrophy. The ventricle wall is trying to push harder and it's getting bigger. It's like when you work a muscle, how it gets bigger. The ventricle wall gets bigger and harder, but what happens, it does cause some restriction to flow in there, and it causes all kinds of problems in its own. It's not the ideal situation. Also with high blood pressure, more likely to have strokes because the blood vessels may burst inside the skull, inside the brain and stuff like that. May cause elevation of blood sugar levels, all kinds of stuff. Causes bleeding. And in the retina, the backside of the eye, they get these retinal hemorrhages. It also causes the kidneys to have to work harder, okay? And as a result, we have kidney disease, hypertensive kidney disease that will occur as well. So, but here we're talking about hypertensive heart disease, and the heart's having to work harder because it's trying to push against resistance to that flow because the vessels are narrower, okay? So that's what we call hypertensive heart disease. This right here is something that you may have. Somebody in the class may have this. And you may have it, you might know about it, okay, and you might have it, and you might not know about it. And it's called mitral valve prolapse. So I don't want to get you scared, okay, but usually it doesn't cause much of a problem. We know that mitral valve is the valve between the left atrium and the left ventricle. We should know that bicuspid valve between the left atrium and the left ventricle. Well, what happens is, if I look at the valve, okay, if I look at the valve comes down like it comes a leaflet like that, and the bottom of the leaflet's like this. It has these strings that attach down to the walls, the muscular walls, and the ventricle. You can see those strings like down on here. For some reason, and some people, and it's nothing you did or anything like that, these strings, or they're called chordae tendineae, they're a little loose. So when the valve closes, instead of closing flat like this, the top of that mitral valve actually pouches this way, goes up this way. Let me just draw that in white. It actually bulges up like this. It should be closing flat like this, but bulges up, which means it doesn't quite close all the way it should. And some of the blood's going to leak from the area of the left ventricle back up into the left atrium. Okay. Now, a lot of times, again, this doesn't really cause a problem, a physical problem, but somebody goes and they go to the doctor, they listen and say, I hear a little murmur. And this will cause a little mitral valve prolapse murmur. There are certain maneuvers they're going to have you do. They will actually bring this murmur out, be able to hear it a lot more clearly. But what happens is a lot of times it means that the mitral valve is it need to be replaced? Usually not. Usually doesn't. But it means it's a little bit more vulnerable to things like infections and stuff like that. There's something structurally wrong. So when people have like dental work, when they're having extractions or dental cleanings and stuff like that, if they know they have a mitral valve prolapse, what they usually do is they usually give them prophylactic antibiotics. What I mean by that is they give them a large dose of antibiotics like an hour before they have the dental work. And what happens is by the time that they're doing the dental work, the antibiotics are now in the bloodstream, they're passing around, and as a result, when they start scraping on your teeth, what it does, it causes a shower of bacteria from your mouth into the bloodstream. If I have the antibiotic in the bloodstream, it takes care of the bacteria, so it doesn't worry about causing a problem, because this valve would be a nice focal point for that bacteria to settle on. So they just worry about that, okay? And that's what they do with this mitral valve prolapse. So if somebody knows they have it, they just give them a prophylactic antibiotic before they do dirty procedures, like dental work and stuff like that. They give them an antibiotic, and they're fine, in most cases. Okay, and that's called mitral valve prolapse. The next thing we talk about is a murmur. I'm getting rid of my picture here. What a murmur is basically an abnormal sound when we listen to the heart. We take that stethoscope and listen to the heart. We'll hear these crazy sounds sometimes. Normally we should hear a lub-dub, 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 and the space between the lup and the dub should be relatively clear. You shouldn't hear a whole lot. But sometimes you hear a whoosh, 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 between, or a and these are abnormal sounds. And what the abnormal sounds are, it either means that the valves one of the valves is not working quite right and either not letting blood through, which is called stenosis, or open too much and lets blood go backwards where it shouldn't go, which is called regurgitation. Or it might be because there's a hole in the wall of the vessel, or that little ductus arteriosus is open, or something. There's multiple things that cause murmurs. Okay, so some murmurs are actually mean nothing. They're called functional murmurs, or and it doesn't mean a whole lot. You know, some people with even iron deficiency anemia, they might have a little murmur, and then what happens? They take the iron, they get their blood built back up, and all of a sudden the murmur goes away. So these murmurs could be something significant, where a valve is either narrowed or too open or doesn't close. There could be a hole somewhere, whatever the case may be. These are investigated by a cardiologist, and they're able to determine if the murmur is what's called pathologic, which means it results in a problem, or if it's non-pathologic. But these are just those abnormal sounds that people would hear, or that the physician or the medical practitioner would hear when they listen to the chest. Okay, and this is sort of like, this is when we look at this little chart down in here, this is a little chart that shows how some of these murmurs sound if we were looking at them as a sound wave. Okay, and those are called murmurs. Okay, pericarditis. Now we know that the heart is in a sac, and that sac is called the pericardium. Okay, and what happens is sometimes the inside lining of that sac, the inside membrane of that sac, becomes inflamed. When it becomes inflamed, the pericardium normally has a little bit of fluid, and that little bit of fluid's there to allow the heart to beat, you know, unrestricted. You know, we don't want to have the heart stuck to anything. So that fluid is slippery to allow the heart to move evenly inside that sac, which is a great thing. However, if I have an inflammation and that sac starts to fill up with too much fluid, what happens, that sac can only stretch so much. If it keeps on making more and more fluid, what does it do? It starts squeezes the heart. The heart can't fill the way it should, and the blood flow that's coming out of the heart, therefore, is going to be decreased. Okay, a lot of this could be either bacterial, or it could be viral. There could be lots of different reasons, but it's basically an inflammation of that pericardial sac around the outside. Fluid builds up inside there. Sometimes do what's called a pericardiocentesis, where they actually take a needle through the chest wall, stick it in the pericardium, and then suck the fluid out. They still have to figure out why it is to treat why it's happening, because it's going to come back again. But that's just called pericarditis. Okay. A couple other pathological things we have. One's called an aneurysm. Now, an aneurysm is a ballooning of a blood vessel, okay, usually an artery. Now, this right here, if we look at this image right here, okay, this is basically a picture of the abdomen. Actually, we see this is an angiogram. There's a kidney right there. There's going to be a kidney in this mishmash over here. Here's the aorta right here. And if you look right here, there's this big ball right here, and that's the aneurysm. That's an abdominal aortic aneurysm. Okay, it's down here's where the aorta is starting to divide, going to a right and left side. But this is that abdominal aortic aneurysm. They're not uncommon, and this is probably much more common in males than in females. Okay, and unless it gets to a certain size, they sort of watch it. But sometimes the aneurysms can get so big that they'll just pop. And when they pop, guess what? The blood goes all over. And because you got to remember, there's a lot of high pressure of that blood in the aorta, and that blood will fill the whole abdomen. And if it's not taken care of, immediately these people will die. Okay, and that's just basically called an aneurysm. Aneurysms occur in the brain when they're in the brain. Sometimes they have what's called a baryaneurysm. And a baryaneurysm is like if a blood vessel and one comes out this way and branches out. Sometimes right there there'll be a little bulge right there, and they call them baryaneurysm because they look like a little berry on a stalk. And if the pressure gets high in there, especially if somebody has high blood pressure, it may get stretch it out, 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 stretch it out until it can't get stretched anymore, and it bursts and it sort of erupts, and that blood leaks out, and that's what we call a stroke. And again, these may occur as well. There are other different types of aneurysms. There's one up at the aortic arch, which is very commonly fatal. Okay. If you're a fan of some old TV shows, Three's Company with John Ritter, you know, he wasn't feeling well one day when they were filming the TV show. They took him to the hospital, and a few hours later he was dead because he had an aneurysm that was up at the aortic arch, and it went actually down and dissected all the way. It's called dissecting aortic aneurysm. It went all the way down, and it actually sort of, instead of being a pouch like this, the wall, they create a false channel in the wall. And what happens, the blood, because high pressure, fills that false channel and makes it bigger and bigger and bigger and bigger. And this one actually went down and actually stopped and went down all the way to the valves, the aortic valve. And the aortic valve starts working, it opens up, and then the heart function goes down, and it's a really mess. So anyway, an aneurysm is these little bulging area, ballooned out area of a vessel, okay, that may burst, and that's one of the risks that they have, okay, and that's called an aneurysm. This one right here has to do with what's called deep vein thrombosis. Okay, We talked about this a little bit before about peripheral, phlebitis, okay, or thrombophlebitis. And if you look at these two calves, one calf looks big, this one over here, and this one looks smaller. This is the normal side over here. This one's called deep vein thrombosis. Well, it could be. You could still have a thick, big calf, but not a deep vein thrombosis. But here's the problem: is when that vein in the leg starts to clot. That's one thing. If that clot moves and gets loose and breaks off, it's going to start to go up the leg. When it goes up the leg, all the vessels are getting bigger. Where does it go from the leg? The inferior vena cava. Where does it go from the inferior vena cava? To the right atrium. Everything is getting bigger. Where does it go from the right atrium? Right ventricle. Still getting big. Where does it go from the right ventricle? Out the pulmonary artery. Big, but now getting smaller. So that embolus, and embolus means a moving mass of something through the vessel, the embolus starts to encounter smaller and smaller and smaller and smaller and smaller and smaller vessels and causes a blockage. As a result, what happens, they can get air in there, but if they can't get blood in there to exchange the gas, people's oxygen levels go down, their CO2 levels go up, and as a result, it may be fatal. My dad died of a pulmonary embolism. Okay, so that's the big risk of this deep vein thrombosis. Most pulmonary emboli start in the calf. Most of them are in this region of the calf. And what these people are done is they put them on some type of an anticoagulant. They always say blood thinners. Blood thinner is a bad word because it doesn't really thin the blood. Anticoagulants are better. It just means that they don't clot the same. They clot slower. And then sometimes they actually put a little like a sieve up in here in the vessel to catch a clot if it breaks loose. Okay, but once it breaks loose, it could be a big problem because where is it going to go? It's going to go to the lung. Okay, and there was a guy that was back in Desert Storm, a newsman, who was in a embedded news person in one of these little carriers, troop carriers, and he was sitting cramped up in this troop carrier, and he was a young guy, and all of a sudden we hear on the news he died. I said, what in the world, did he get hit by an explosive or something like that? Nope. He had a clot because of his inactivity, because again, what moves the blood upward? Muscle contraction moves it upwards, and those valves prevent it from coming back down, but he's sitting there. And the blood's not being squeezed out of the legs. All the blood coagulated or set in his calf, it coagulated, and then all of a sudden one of those big clots in the calf veins broke loose, went up to his lung, and caused him. He was now in the middle of the desert, and before they could get him medical care, he died. Okay, and that's called pulmonary embolus, PE. You see the commercials. I'm living with a history of a PE. I'm taking an anticoagulant, you know, and basically they're doing that so the blood doesn't clot, so they don't get the clot in the calf, like I mentioned there, which starts the ball rolling. Usually doesn't come from the arm. You know, arm is very unusual for it to happen. Most time it's in the calf. Okay, so that's called deep vein thrombosis. Now, peripheral vascular disease. Peripheral vascular disease is a large catch-all term that means the vessels in the periphery are bad. Okay, and what we're seeing here, this is a peripheral arterial disease. Okay, and this image right here, this is an angiogram. Okay, so this is an angiogram, and the angiogram they put dye. This is the femoral artery. You can see it right there. It doesn't look really great, but if you look at the femoral artery right there, it stops right there. See all these squiggly little things, and those little things are called collaterals. They don't really help much. They're better than nothing, but not that much better than nothing. Okay? And as a result, the vessels just stop there. Why? Because it's all totally occluded off. And that's called peripheral vascular disease. One of the problems we get with peripheral vascular disease are pretty nasty things like that. Okay? And what happens is now we start to get, this is a dry gangrene. Okay? And dry gangrene is nothing more than mummification. Okay? The blood supply doesn't get the blood vessels blocked to this toe. You know, this toe right here is the blood vessel supply is blocked, and as a result, what happens is the toe basically dies. That's just all mummy type toe that sits right there. Seen tons of people with this. Then what happens? They come in, they have a black toe. They either didn't do anything about it earlier enough, you know, to try to come and say, hey, I have a problem with this toe, until it gets really bad, and sometimes they just fall off. They get so dry and dead, they'll just take them, they'll wiggle them, and whoops, it breaks off right where the dead part is. I've seen that happen. People come with a baggie, with a toe and a baggie, you know, and basically I say, wait, what can I do with this toe? Like they want it to be reattached. You know, I would probably say, well, just drill a hole and you could wear it on a chain around your neck. It's sort of like a, conversation piece or something like that. But that's called dry gangrene. Dry gangrene is dry. That's why they call it dry gangrene, and it's mummification. And that's compared to what we call wet gangrene. And wet gangrene is basically in a situation like this, okay? And this is a wet gangrene type of a problem. And wet gangrene means that they lose the blood supply. If you look at this foot down here, okay? If you look at this puppy down here, guess what blood supply is there? Almost nothing. There's no blood supply. But what happens, what makes it worse is this is all infected. Okay, that whole area is all infected, which then becomes a risk to life. Makes sense. How do we treat an infection? And right now you're saying, well, why don't you give an antibiotic? Right? I'm sure somebody out there was wondering that. Guess what? It doesn't work. Why? If there's no blood vessels to bring the antibiotic down to this area, the antibiotic's never going to get there. Okay? All dressed up, no place to go. Okay, so as a result, these are usually resulting in amputation unless they could really emergency-wise revascularize them, and that's called peripheral vascular disease. And this right here would be wet gangrene. Okay. Now Reynolds disease. Now some people may actually have this. Okay, and what Reynolds disease is basically a situation where there's a little bit of a hyperactivity of the vessels. If you look out here, see how it's white. When they get exposed to cold, these vessels will go into a spasm, and actually the area gets the blood supply to the tips of the fingers, also maybe the nose, the ears, and stuff like that, the toes. The blood supply goes down, and they turn white. Okay, and then what happens is the body says, you know what, we can't let that go on because then it's going to cause those tissues to die. And what it does is tries to send other blood supply there. So it goes from white to blue. Blue means it's what? Cyanotic, which means it has decreased oxygen, and it goes to red. It goes from white to blue to red. Red means that now they send more blood supply in there just to try to warm it up and send the blood supply because it's been for a while without. And this is called Reynolds. It's associated with a lot of things like a number of connective tissue disorders like scleroderma, a number of sarcoid. It could have all this stuff like that that go with the Reynolds phenomenon or Reynolds disease. Or it just might be idiopathic, which just means that it's just there. People who have this, you just tell them, hey, sometimes all you need to do is just wear gloves when you're outside or when you go into the refrigerator. Sometimes people just going in and getting a gallon of milk out of the refrigerator will cause a response like this to last for a while. And then you got to remember if there's no blood supply. So like when you know a part of your extremity, like you say, quote, falls asleep when you bend it and the blood supply goes down, it hurts. Okay, so these become quite painful, and that's called Reynolds disease or Reynolds phenomenon. Here are the varicose veins that we talked about before, and the varicose veins. I probably showed you this picture. This probably came up in the last, or at least some type of a picture that is similar to that. And basically, these veins are there because what happens is those valves stopped working. For one reason or another, the valves that actually prevent flow of blood. Again, those valves, we want the blood to go upwards. And so when it goes up, these valves will open, but when the blood tries to come down, the valves will close. If those valves don't close, then the blood comes down, and because of gravity, it starts to pool in all these vessels. The vessels start to dilate, and those are called varicose veins. The problem is these are superficial veins. The superficial veins meet with the deep veins. On the outside, we have superficial veins, and then in the muscle, we have the deep veins, and then we have what are called communicating veins that go between the two. So if these are bad, it actually forces more blood into the deep veins, which actually causes more problems and more likely a problem that may develop in the deep veins. And the deep vein thrombosis is called deep vein thrombosis because it involves the deep veins, not the superficial veins. But these veins may actually cause a problem with the deep vein flow, which then causes a deep vein thrombosis where the clot forms in the deep veins. Okay, a couple tests that we have here. Okay, first one's called a BNP test. Okay, and this one I could just explain because there's really no picture to show. And a BNP test is one where when blood comes back to the heart, the ventricles start to stretch. The cells of the muscle, the ventricle muscle, detect that stretch and they put out a chemical called BNP. And this BNP, what it does is it actually stimulates the heart to beat stronger, to pump things out. So if I have more blood that comes back to the heart starts to stretch because more blood, the BNP is released by the cells. It says pump stronger and pump harder, and it pumps harder to pump that blood out. What happens is people have a heart disease or heart failure. What happens is I have a lot of blood coming back in and the vessel starts to stretch, okay? And when the ventricle starts to stretch, what's it going to do? It's going to release BNP. But if the muscle's not strong enough to pump, it's like, doing nothing. So the BNP levels will rise, but the failure gets worse simply because the heart can't pump any harder. The BMP says, pump harder, pump harder, pump harder. But the heart says, I can't do it. I can't do it. I'm just too weak. I can't do it. And as a result, what happens is the BMP levels in heart failure will continue to rise and rise and rise simply because the ventricle keeps stretched, and it's not strong enough to be able to pump out what it is. The BMP is doing its job saying pump harder, but the muscle can't do it. Okay, so that's a BMP test. Lipid profile and lipoprotein electrophoresis I should actually put together. Lipid profile looks at the number of lipids or blood fats that we have, cholesterol. There are different things called an HDL, okay, HDL, LDL, and this HDL stands for high density lipoprotein. LDL says low density lipoprotein, okay? And low density lipoproteins are damaging. They actually cause that corrosion and that inflammation and that irritation on the inside of the vessels. HDLs are good. That's that good cholesterol that people have. They actually start to help to remove these deposits. We have another thing called a VLDL, chylomicrons. There's all these blood fats. And what happens is the reason why they look at this lipid profile is what they do is they get some blood. Now, this is interesting because what happens is sometimes people say, hey, you want us to check your cholesterol? You say, yeah, you check it, and all of a sudden it's high. Well, guess what? They have to fast for 12 hours. They need a 12-hour fast for an accurate result. So if you've just gone to the food court, ate a Big Mac, and someone in a mall has a health fair and says, check your cholesterol, guess what? You just finished your 2 Big Macs, your cholesterol levels are going to be high. Okay, so they fast for 12 hours and then they take some blood, just regular venous blood, okay, and they look at, they categorize and see what's the levels of this large number of different types, and these are only some, large number of different types of blood fats, and they're able to actually create a picture as to what they think your risk is for developing heart disease, or a myocardial disease, coronary artery disease, and stuff like that. So this is what they do that for. So people who are at a risk, you see on the TV sometimes commercials for I take simvastatin, or I take a number of these cholesterol lowering agents, and basically they're just medications that try to lower the LDL and my total level of cholesterol, and hopefully the HDL levels will rise, will help a little bit. Now, how they determine this? What they do is they would sometimes call lipoprotein electrophoresis. They take a little bit of the serum, okay, which is the liquid portion of the blood where these fats are. And they take a little bit of the serum and put them in these little wells at the end of a gel tray. And they apply electrical current for it. That's so they get the electrophoresis. And what happens is, again, high density lipoproteins are larger, low density lipoproteins are smaller, VLDLs, very low density lipoproteins, are really small. Depending upon the size of that molecule of that fat, it's going to move in that, it's going to either move more or a shorter distance. It's sort of like having a big person walk in water versus a very narrow person walk in water. You're going to have a race. I'm betting on the guy who's very slim and slender. Why? Because there's not much water resistance. So if a larger molecule, it's not going to migrate as far in that gel bath when they apply an electrical current. It's like a cattle prod. They zap with a cattle prod and make those proteins move. So one lipoprotein is going to go a long way, one's going to be a little bit less, one's going to go a little bit less, based upon the size. And then they look at the amounts of those, and they could give that picture of what lipoproteins are there and what volume, what concentration they are. The last thing on here, I have a serum enzyme test. Okay. Now, what happens is when somebody has a heart attack, there's a couple ways to determine they're having a heart attack. Number one, by history. But you know what? There's a lot of things that sound like a heart attack that aren't a heart attack. You say, I'm having chest pain. Could be lots of things. So that's not a really good way to do it. Well, what's the second way? Well, I could get an electrocardiogram. The electrocardiogram shows abnormal electrical activity. And if I get a 12-lead electrocardiogram, I'm able to see not just if they are having a heart attack, but where they're having the heart attack, because a 12-lead electrocardiogram looks at the heart from multiple different viewpoints. Okay? But the problem is sometimes I don't get that change in the electrocardiogram for a few hours. What's the third way? Well, what happens is when the muscle starts to die, because of this, quote, myocardial infarction, inside that muscle cell, okay, are various enzymes, okay? And one of them is called troponin. And what happens is the troponin, when the muscle cell dies, the troponin is released from that muscle cell and now gets in the blood. So therefore, if somebody's having a heart attack, this troponin level is going to rise in the blood because that's where it's going to go. In other words, it should be a very low minimal level, almost like nothing. But what happens if I start to see this level of troponin rise in the blood? I know that it's the only place it's coming from is that heart muscle, and the heart muscle must be damaged or destroyed to release the troponin into the blood. So they do that. There are a couple of other tests that they also used to use, probably not as much. One is called a CPK. Okay, they could use that creatine phosphokinase, which also may show a heart attack, because again, that's also in a muscle cell. There's another one, LDH, and they could divide the LDH in multiple different what we call fractions, and one of them has to do with myocardial cells and stuff like that. But what happens is serum enzyme tests are used to look for myocardial infarction when these enzyme levels increase in the blood, because now the cell is dying, the myocardial muscle cell, the sarcomere is dying, and therefore now all the chemicals are inside that are released. Where they go, they get picked up in the blood and they're transported around, and therefore the blood levels will rise in those. And those are called serum enzyme tests, and they're used to look for heart. Okay, a couple other clinical procedures I'll get through real quick. Okay, angiography. Okay, angiography is like we talked about before, and this is an angiogram, basically sticking dye in a vessel and see where the vessel goes, and looking for abnormal where it becomes narrowed, areas where it might become narrowed or the blood flow stops. Okay, and this is done by cardiac catheterization. They stick a, like I say, I've probably had this like about 5 times. They just take a needle, stick it in your femoral artery, and pass it all the way up the aorta through the aortic arch, and stick it right where the coronary arteries start. The aortic valve is right here. Again, the coronary artery is right here, and the coronary artery is right here, with the aorta coming up this way. And they stick the tube, that end of that catheter, in that little area right there, send dye down there and see where the dye goes. And that's called angiography. Angiography also can be used on the vessels of the legs, like we showed before, and stuff like that. Okay. Now this is a cerebral or a neck angiography. Okay. So basically we're seeing, this is the head right here. Okay. This is the head, and basically this is the area of the heart down here. Okay, and basically what they're doing in this situation, this is a computed tomography angiography, and what they're doing is they do a CT scan, and they're actually looking at the blood flow here. So these are all the blood vessels that go into the neck. I could go through all these, you know, some of them are called the vertebrals, and we have the carotids and stuff like that, and that's the computerized tomography angiography. Okay, so that's what we see in this. This is just looking at the head and neck. And it's probably, we probably use more computerized tomography, angiography in looking at the circulation to the neck, to look for if the blood supply, if the blood supply in the neck arteries, because again, here's the top of the skull, this is the neck down here. If the blood supply in the neck is blocked off, and part of the brain's going, our blood supply to the brain is going to be diminished as well. Okay, now this right here is called digital subtraction angiography, and this is sort of like helpful for people who might have do Photoshop and stuff like that. I can actually do something in Photoshop where I could actually take a picture and take things away. You sort of mask those areas and take them away. And what they do with digital subtraction angiography is they get a picture of the skull. The problem is when I have the skull, okay, CT scan takes slices. So that's why we saw it on the last one. We see slices, and you're going to see where the vessels are in slices. However, if I'm just doing an typical angiogram, what stops or what actually gets in the way of seeing the angiogram? The bone. So what they do is they take a picture of the skull. And after they take the picture of the skull, okay, then they get this angiogram. They inject dye. This is the carotid artery that's going up and supplying the brain. This is the brain right in here. It's supplying the brain, and you can see the same thing over in here, okay? And then what happens is then they digitally subtract, because again, these x-rays are taken digitally. They can remove things or they can mask things. So what they do is you can see a little remnant of where the skull is. They decrease the intensity of the skull, and they magnify or accentuate the intensity of the angiogram. And this is called a digital subtraction angiography, because what they do is they digitally subtract the bone, so you can't see the bone, so what you see is the angiogram. That's called DSA. Okay, it's pretty cool. Okay, this right here is just another image of looking at the heart. Okay, and again, over here we see angiogram over there. What they do is they could do what's called electron beam computed tomography, and this is a tomogram. Tomogram just means it's cut in slices, and what they're able to do at this point is they're actually what the electron beam computed tomography. This is again looking at the heart. This is actually a great picture looking at the heart. And you can see that here's a coronary artery right there. You can actually see it coming down the front. You can see it going around the back. So this is right the left coronary artery right here. Okay, the right coronary artery would be right here. Okay, what happens is you're seeing the heart, and the reason why they're doing this is they're actually looking for, in most cases, for calcifications in the wall of the coronary arteries, and that's where electron beam computed tomography usually comes in the most. Okay, it's done more than we used to do, but it's still done. This is a Doppler ultrasound. Okay, now if you're standing at a railroad crossing and a train's coming, and the train's blowing its horn, when that train gets closer to you, the sound is different. Okay, and that's called the Doppler effect. Okay. Well, what happens is by using ultrasound, I can aim that ultrasound at a vessel. So in other words, they take the ultrasound head up here, they aim the ultrasound at the vessel, and they can determine blood flow. And this red right here, because it's a faster flow, is going to come out and be looked at as red. This blue that we have in here, slower flow, comes down as looks at as a venous blood or vein blood, which is under lower pressure. So basically, they're able to look at the carotids, they're able to look at a number of vessels, and when people have a deep vein thrombosis, they can actually look at the deep veins of the thigh or the calf, excuse me, to look to see if there's a clot and see a big area there'd be a clot inside there. This is called Doppler ultrasound. Okay, and it's basically using sound waves to actually detect the flow of blood going through vessels. I know every year I go look at my carotids because my right carotid is about 70% occluded on the right side. It's been staying like that for a bunch of years, so I don't think it's going to probably get any worse at this point. I'm 70, so it's not going to happen much more after this. But what happens is they do a Doppler ultrasound of my neck just to see if the carotids are any better. Okay, echocardiography, and this is echocardiogram right down here. Okay. And the echocardiogram is basically, again, using the same thing. It's using ultrasound. And the ultrasound, actually, what it'll do is it looks at the heart walls. And you can actually see, like, the chambers. And you actually image the heart. It's a non-invasive procedure. You can actually see multiple things in the heart. You can see the heart walls moving. You can see the valves moving and stuff like that. And that's just by using ultrasound. Ultrasound, echo of a sound. What happens, the ultrasound hits something, bounces back off, comes back, and they pick it up in a transducer, and that gives us an image. And that's called echocardiography. So we're able to look at the walls of the heart, how the heart's moving. They can also measure the amount of volume inside all the chambers as well. Okay, that's where they get that thing we called before, that ejection fraction. They can actually take a volume measurement by measuring the size of the ventricles at certain points of time, systole, diastole, and they know how much blood's being ejected by the size change in that. Okay, and that's called echocardiography. Okay, I go for an echocardiogram probably every 2 years. This right here is, again, going what's called a positron emission tomography, or a PET scan. And what a PET scan is it's like a CT scan, okay? But what happens is before they do the CT scan, they inject people with glucose that's radioactively tagged. Cells that are working overboard, such as in cancer cells or stuff like that, need more energy because they're working faster. They're dividing faster. They need more energy to be able to survive. And as a result, what's going to happen is the glucose goes to those areas because the glucose is a fuel source. And the glucose is tagged to the radionucleotide, so it causes a hot spot or an image. So what we're seeing right here on this one over here, here's obviously a brain, and we see this area right here, which is a hot spot, which is some type of a tumor in the brain. They can actually localize where it is. Here's the anterior portion out here. This is posterior. And so you see the eye right there. There's an eyeball right there. So it's just behind the eye, looks like on the left side. Okay, and they're able to see that. And this is just looking, here's the heart right there. You can see where that area is lit up a little bit. But again, that's because the heart's pumping a lot. So the PET scan basically is looking at areas that are metabolically more active, that require more energy, and by injecting the glucose that's radioactively tagged, that area is going to migrate to the area that needs it more. And frequently that's an area of a tumor. So a lot of times they look for areas of tumors with what's called a PET scan. Okay, and this right here are perfusion tests. This is called a stress test, a technetium-99 or a thallium scan. And what they do is they combine this with the stress test. And with the stress test, what they do is they stick you on a treadmill or they give you a medication that stimulates you being on a treadmill or exercising. And what they do is they make the heart work harder. And then what they do is they'll inject this material, this technetium-99 or thallium-201. And what that does is it's going to show the blood perfusion to the heart. Now, if I have an area of the heart that's not working well because the muscle's dying because the blood supply is going down, guess what goes to that? Nothing, or a lot less. So they take these scans, they take the scans right after the exercise, and they take it a couple hours later, and they compare it. If there's an area that's void of blood flow because the scan doesn't show any material going to a certain area, both at the just after exercise and later on, or sometimes they do it before. If they do it that way, then what happens is in those situations, that means that it's an old injury, that there's a scar there, it's not going to go there. However, if they have a person who during exercise there's an area without perfusion, but later on it's perfusion, it means that's a person that might benefit from a bypass. Because it's sort of like something it's checking out the circulation before it causes a big problem. And that's what we see with these perfusion tests, the technetium-99 or the thallium scans that go along with these stress tests. Okay, and let's see with that. This is me. Okay, this is me. This was in 2000, and basically this was looking at one of my cardiac caths, and that area was a little bit narrowed right there. So what they did was, after they did this, my cardiac cath, you can actually see it right there. It's narrowed. Here's the catheter coming up from my leg, loops around through the aorta. This is the aorta right here. This is where the aortic valve would be right here. Here's the branch, and there's where it's narrowed. What they did is they went in with another tube that had a wire cage on it. They blew that wire cage up, and that's where it's at right there. You can actually look and you can see it's like little wire walls inside there, and that's called a stent. So if somebody's had a stent, they go in with a balloon. It's called a balloon angioplasty. They blow it up. You can see right here, percutaneous transluminal coronary angioplasty. That's what PTCA, percutaneous means through the skin, transluminal through the lumen, which is the hole, a coronary artery angioplasty, plasty repair of the vessel. So they've blown it up, and I'm fine with that. It's not a problem. This is a before, there's after. Okay, you can see how now I get blood supply there, where up in here I wasn't getting as much blood supply. Okay, a couple other things, cardiac MRI. You know, it's okay. They could take an MRI. This is just looking at an MRI of the heart. You can see here you can see the right atrium, right ventricle, left atrium right in there. You can see stuff like that. So you're able to see the heart a little bit. In most cases, it doesn't have all that much advantage. It can be used for looking at certain areas of defects in the heart and stuff like that. Cardiac catheterization, this is what we were talking about before, and this is how they do it. Okay, this is how they do it. Okay, what happens is, again, here's the catheter. They put it in the femoral artery. They pass it up this way, and it loops up through the aorta. They stick it in there, and then they stick and here it is coming through the aorta, through the aortic arch. They stick it right here in the aorta right here, where the coronary arteries come out, and they're able to see the blood supply that's coming out, and that's called cardiac catheterization. Okay, again, yeah, there is some risk to it, but it's not that bad. Electrocardiogram, this is a 12-lead electrocardiogram like I talked about before, okay, where by taking 12 leads, I'm able to actually see what's going on. This case right here was interesting because if I look right here, and I don't expect you to remember this, this is lead 1, and that looks at the left arm sort of, and this is over here is V5 and V6, which is sort of at V4 over here. These are chest leads, and I'm seeing with this area right here, this area right here, and this area right here, this area right here, and this area right here are telling me this is a heart attack that's occurring, and it's on the lateral side. It's called lateral MI. Okay, and so what these 12 leads are: lead 1, lead 2, lead 3, AVR, AVL, AVF, V1 through V6. What they do is they actually look at the heart from 6 different vantage points. Okay, actually 12 different vantage points. 1, 2, 3, or 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Looks at the heart like taking a picture of the same thing from 12 different points of view. So that's why these all look different, and they're able to actually see what's going on. Okay, so that's called an electrocardiogram. It's a 12-lead electrocardiogram. Okay. Now this is a Holter monitor, okay, and I hated my Holter monitors. I had a couple of these. And what the Holter monitor is when they put you on a table and measure electrocardiogram, guess what? It's when you're sitting there resting. It's not when you're exercising, doing anything else. So if they're looking for heart disease, a lot of times what they'll do is they stick this little box on you, okay? And it could be this, it could be hanging from your belt, it could be hanging from a big patch around your neck, all kinds of things. And they put the electrocardiogram leads on you, and they send you out. They send you out for 24, 48, 72 hours with this sucker on, and I always get humongous. irritation and rashes underneath where all these leads are attached. But what they do is they monitor your heart rate. Okay, they monitor your electrocardiogram for whatever hours they set into that. And it's stored in a computer right here. And then what happens is you bring this box back after the 24, 48, 72 hours. You give them the box back. And what they do is they read the electrocardiogram that shows a couple days worth of your electrocardiogram. They tell you to do everything you normally do. Run, eat, exercise, whatever the case may be. And then what you do is you keep a little log, say what you did at what time. They compare that with how the electrocardiogram looked during this long strip that they have in there, and they're able to determine a lot of things. That's how I found out that my heart was doing some crazy things, is by using a Holter. Okay, so that's a Holter monitor, because again, that it takes about 5 seconds to get a normal electrocardiogram when you're lying on a table doing nothing. So this is actually a much more dynamic way to do it. And the last thing here I want to talk about is basically a stress test. Okay, and the stress test is what we have where they're hooking you up and they put you on a treadmill, or they give you a medication that stimulates actually heart activity. They measure your blood pressure. They have you hooked up. All these go to a monitor, so they watch your heart, and they're actually checking to see what your heart does when it's stressed. Because again, you might have heart disease, but it might not show unless the heart is being stressed. So by stressing the heart, they're able to actually see if there's something going on. And this is called a stress test. Okay, I've had probably about 4 or 5 of those as well. Actually, probably more than that. Probably had one. I see. My heart attack was a long time ago. It was 1987. So I mean, I've had multiple stress tests, and that's what that stress test really is all about. Okay. A couple other things I want to mention here, and then we'll go to a couple abbreviations, which I'll actually put in another video. I'll stop at that point, but I want to finish this. Cardioversion. Okay. Cardioversion is what happens is sometimes when people have atrial fibrillation, what they do is they stick them in, they give them a little, they sleep them a little bit, give them a little medication to make them drowsy, and they zap them with electrical current, and they try to convert them into a normal rhythm, and that's called cardioversion. Okay, for people with atrial fibrillation. Okay, and that's cardioversion. There's that coronary artery bypass, and this shows actually the two things. Here's where they actually take the vein from the leg and they attach it to the coronary. This is the one that internal thoracic. And what they do is they just find where the area is blocked and they attach the artery beyond that. And that's called a coronary artery bypass graft. Or if someone says, hey, I had a cabbage, it's not like something they ate, coronary artery bypass graft. And that's just basically what they do. Okay. This is an endarterectomy. Okay. Endo means within. And what an endarterectomy means is if the blood vessel is blocked in some way, okay, particularly in the neck, frequently these are in the carotid. What happens is they could actually go inside, they put you to sleep, they do a surgery, they go in, they find the carotid, they actually stop the blood flow for a short period of time with the carotid, they make a cut in the carotid, pull out whatever's in there, the plaque, they clean out, they roto-root it inside the inside, pull out all that plaque. Now the risk is sometimes people have a stroke because part of that may break loose and then go up to the brain. But they pull out that inside, and basically then they sometimes will actually put a stent in there to hold it open just like they did in the heart. And that's called an endarterectomy. Okay. This is extracorporeal circulation. Extra means outside, corporeal means body, corpse means body. What happens is when they do heart work, when they do cardiovascular surgery, when they want to go into the ventricles, they don't want to have a little blood going there, do they? Okay. When they're doing open heart surgery, they don't really want to have blood going through, because what happens, you make a little squirting all over the place. So what they do is they actually put a bunch of tubes in to bypass the heart, and they send all that circulation through this heart-lung machine, which does the same thing that the heart and the lungs do, and that's called extracorporeal circulation. So, and then what happens is once they get everything done, they take you off this heart-lung machine, reestablish the blood supply going through the heart, and everything's fine. When they do a lot of open heart surgery too, guess what they don't want the heart to do? They don't want it to beat. So what they do is they actually add a paralyzing solution in the pericardium around the heart. Once they open the pericardium, it looks like a trough. They fill it with this ice-cold slushy paralyzing solution. It sort of causes the heart to stop. The heart will actually stop. So I need to have the blood flow going. Okay, the heart stopped, but the blood flow has to go. Why? Because this machine right here provides the circulation, provides all the taking out the carbon dioxide, putting in the oxygen, and it causes the force to be able to force the blood through the vessels. So it's taking the place of the heart and the lung. When they're done with the surgery, they suck that fluid out there, okay? And then they stick 2 paddles on, stick it next to the heart, you get a zap, boop, 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 it starts beating again, okay? And that's called extracorporeal circulation with that heart-lung machine, okay? Now, heart transplantation. Heart transplantation has been around for a long time. Cleveland Clinic and University Hospital do tons of these every day. These are happening all the day. I remember when the first one was actually in South Africa. Okay, and I remember when I heard about that years ago. Wow, this is a really pretty cool thing. But now basically they get a donor from someone who has passed away. They salvage the heart, or they harvest the heart. They have a certain amount of time, a very limited time, where that heart stays like this. They pack it in a cold solution, so it doesn't need a whole lot. In other words, you stick it in ice and stuff like that, in a paralytic solution. So what happens is it could survive longer. If you leave it out, it's going to rot. So what they do is they put it in there, they take it out of there eventually, and they put it back in, and they implant it in, and then they go ahead and start it again. And that's just heart transplantation. Now there's tons of those. They're a dime a dozen. They're going on all over the place. Okay. Percutaneous coronary intervention. Now this is what I had. Okay. And again, they take that catheter and they put that catheter, you can see it here, that catheter is now coming out of the aorta. It's going down in the coronary artery. And right here would be the area of the blockage. And on the end of the tip of that catheter right here is a balloon. And on outside that balloon is this wire cage. So what they do is they get this balloon right where the blockage is. They can see that on the x-ray while they're doing it. They have a constantly monitoring x-ray. They can see where this is. And they get it right here where it's supposed to be. And what they do is they blow up the balloon. And when they blow up the balloon, it expands the wall of the vessel. And to keep the wall expanded, as they blow up the balloon, it also blows up this cage. And that cage is called a stent. Then once they do that, they deflate the balloon, pull out the tube. The stent stays expanded inside the vessel, and they just retract the tube with the balloon, and it comes out, and now the vessel's open, like I showed it to me before. And that's called percutaneous coronary intervention. Okay, so that's that. Last thing I want to talk about here is thrombolytic therapy. Now, you don't have to remember this chemical formula over here. Okay, but what happens is when people have a heart attack or a stroke, they have a clot. Okay, that clot forms, okay, and the procedures, because of the inflammation, blah, 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 like we talked about before, that clot forms. If they could get to somebody right away, they could actually give them some medications that will break the clot. Now, the anticoagulants, those quote blood thinners, which I hate that word, do not break a clot. They just prevent more clot from forming. But they could give some medications, and now the medication they usually give is this thing called TPA, okay? And what happens is this is a medication, if they give it right away, both in cases of heart attacks as well as strokes, you can actually break the clot down rapidly. And by doing that, it reestablishes the blood supply, so there's less tissue that will die. So the effect of the stroke or the heart attack will be less. In my case, they didn't have the PTA, they had streptokinase. Streptokinase takes a couple hours to work, and basically that's why I probably have some defect. I'm still alive, which I should have probably died, because I had some friends really working on me pretty good. But these are thrombolytic, because thrombo means clot, lytic means to break it up, and that's what we see. The earlier they give those, within the first 30, 45 minutes and stuff like that, the better off. They can actually put a catheter in, they can put the catheter in and put it right to where the clot is and put this stuff directly in there, and that sometimes helps right away. And that's called thrombolytic therapy. The sooner they do it, the better it is. Okay, so what we've talked about here are a number of cardiovascular conditions. And again, hopefully this has been interesting, because I think we get away from just some of the boring words and talk about how those boring words actually make sense. Hopefully you've learned a little bit from this. You learned a little bit, maybe some words that you heard, AFib, pulmonary embolus, PE, a cabbage, stuff like that, things like that you've heard of, and now they're going to make a little bit more sense to you, because now we know enough medical terminology that we can actually discuss these things a little bit better. So hopefully this has been informative to you. Again, you can watch these videos as many times as you want. Hopefully it's all good. So we'll talk to you later, and I'm going to let you go now. So y'all be good, learn as much as you can, and be safe.